New federal vaccine guidance has just been issued, sparking urgent questions for parents and pediatricians across the United States. Recent votes by the Advisory Committee on Immunization Practices, or ACIP, have triggered this significant development. ACIP is the expert panel that provides recommendations to the Centers for Disease Control and Prevention. The committee has proposed two major alterations to the long-standing childhood immunization schedule. One change affects the timing of the first hepatitis B vaccine dose. The other concerns the recommended use of the combined MMRV vaccine. MRV protects against measles, mumps, rubella, and varicella, chickenpox. These decisions arrive at a critical juncture for public health. For years, the childhood vaccination schedule has been a stable, scientifically validated framework, designed to protect children at their most vulnerable stages. The proposed changes have been met with support from some parental groups and significant alarm from the mainstream medical community. We'll break down what has changed, why the changes were made, and the potential consequences for families and communities. The stakes are high. Immunizations are a cornerstone of preventive medicine. They shield individual children from severe illness and create community immunity that protects everyone. The first major policy shift concerns the hepatitis B vaccine, a shot routinely given to newborns within hours of birth for decades. The established protocol was designed to prevent transmission from an infected mother during delivery, credited with near elimination of chronic hepatitis B in U.S. children. The ACIP now introduces the option to delay the birth dose. It could be given at the 1-month checkup or later for infants of mothers who tested negative during pregnancy. This departs from a universal strategy in place for over 30 years. The birth dose acted as a safety net, ensuring all babies were protected immediately. The virus can cause lifelong chronic liver infection, cirrhosis, liver cancer. Infants are especially likely to develop chronic infection if exposed at birth. The prior universal recommendation covered potential errors in maternal screening, a mother's unknown status, and infections acquired late in pregnancy. It provided a robust layer of protection for every newborn. The Advisory Committee voted, per Stat News, to recommend delaying the first shot by at least 1 month for certain infants. This shifts away from universal application toward a risk-stratified approach. The decision emphasizes accurate, available maternal screening results at delivery. The proponents of delaying the hepatitis B birth dose offer a few key arguments for their position. The primary rationale: for the vast majority of U.S. babies, the immediate risk at birth is extremely low. This is because mothers undergo prenatal screening and test negative. In those cases, they say the vaccine can be postponed until the 1 or 2 month well-child visit. They argue this could alleviate anxieties of parents wary of vaccines right after birth. Advocates also cite reducing medical interventions in the first 24 hours of life that, they say, contributes to a more positive birthing experience and less parental stress. Separating the vaccine from immediate procedures keeps focus on parent-infant bonding. The change is pitched as greater parental choice and tailoring to perceived infant risk. Moving away from a one-size-fits-all model some parents find rigid. Conversely, public health and pediatric communities have voiced profound concerns. Experts fear delaying the birth dose could dismantle decades of progress, nearly eradicating infant hepatitis B. The universal birth dose exists because maternal screening is not infallible. A mother's test result might be recorded incorrectly, or unavailable at the time of delivery, or be a false negative. A mother could also acquire hepatitis B late in pregnancy after initial screening. The birth dose serves as a critical fail-safe in these scenarios. The biggest risk: increased perinatal hepatitis B transmission that can lead to a 90% chance the infant develops a chronic, lifelong infection. The second significant change approved by the advisory panel targets the MMRV vaccine. This shot is a combination vaccine that provides protection against 4 common childhood diseases: measles, mumps, rubella, varicella, chickenpox. For years, parents have had the option of choosing this single injection for their children, typically between the ages of 12 to 15 months, as an alternative to receiving 2 separate shots, one for MMR, measles, mumps, rubella, and another for varicella. The primary benefit of the MMRV vaccine has always been convenience, reducing the number of injections at a single visit. According to NPR's reporting, the ACIP voted 8-3 to change its recommendation, advising against the combined MMRV for children under 4. This decision doesn't eliminate the vaccine, but recommends 2 separate injections for the first dose in year 2. The combined MMRV could be considered for the second dose, typically given between ages 4 and 6. So, the ACIP panel justified its vote against recommending the MMRV vaccine for young children by pointing to a known, albeit small, safety concern. Existing scientific studies have shown a slight increase in the risk of febrile seizures triggered by a high fever, in children between 12 and 23 months old who receive the combined MMRV shot compared to those who get the separate MMR and varicella shots on the same day. While febrile seizures are generally not dangerous in the long term, they can be very frightening for parents, The panel argued that, out of an abundance of caution, it is preferable to avoid this small additional risk for the youngest children. The committee's reasoning prioritizes the minimization of this specific, rare side effect. By recommending separate shots for the first dose, the panel suggests that this elevated risk can be effectively eliminated. However, many pediatricians and public health experts have voiced strong disagreement with this change. They argue that the panel is overemphasizing a very small and manageable risk at the expense of other important public health goals. They point out that the actual increase in risk for a febrile seizure from the MMRV shot is tiny, about 1 additional case for every 2,300 to 2,600 doses administered compared to separate shots. More importantly, they worry that recommending 2 shots instead of 1 could create a new barrier to vaccination, potentially leading some parents to delay or skip the varicella vaccine altogether. Critics of the ACIP's decision believe that the well-established benefits of the MMRV combination shot in ensuring full and timely coverage outweigh the very small and temporary risk of a febrile seizure. Honestly. These policy changes are not happening in a vacuum. They are being introduced at a time when the United States is facing 2 alarming and interconnected public health trends. Declining childhood vaccination rates increase in outbreaks of preventable diseases. According to the latest data from the CDC, vaccination coverage among kindergartners has fallen from a high of 95.2% in the 2019-2020 school year to just 92.7% in the 2023-2024 school year. While this may seem like a small drop, it means that approximately 280,000 kindergartners are now unprotected against diseases like measles. This decline is significant because it pushes community immunity levels below the critical threshold needed to prevent widespread outbreaks. For a highly contagious virus like measles, vaccination coverage of 95% or higher is required to maintain what is known as herd immunity. This is the level at which enough people are protected to stop the virus from spreading easily, thereby safeguarding those who are too young or too medically fragile to be vaccinated. The current national average is now below this vital safety benchmark, creating pockets of vulnerability across the country. The consequences of these falling rates are already visible. The CDC has reported a dramatic surge in measles cases in 2025. As of September 16th, 2025, a total of 1,491 confirmed measles cases have been reported across the country, a stark increase from the 285 cases reported for all of 2024. The recent votes by the ACIP cannot be fully understood without considering the significant political shifts that preceded them. In a highly unusual move earlier this year, the entire 17-member advisory panel at the CDC was dismissed by Health and Human Services Secretary Robert F. Kennedy Jr. This was a departure from the normal rotation of committee members. The previous panel was composed of experts in immunology, pediatrics, public health, infectious diseases. They had long track records in vaccine science and policy. The former panel was replaced with new members. NPR reported the new appointees include people with critical views on the existing vaccine schedule and ties to groups historically skeptical of vaccine safety. Critics, many in science and medicine, say the new panel lacks broad expertise and impartiality. They worry decisions may be driven more by political ideology and financial interests than rigorous, unbiased science. The controversy was further amplified by public statements from the former CDC director, Susan Monarez. According to MSNBC, Menares said she was fired in part because she refused a request to pre-approve the advisory panel's anticipated changes to the immunization schedule. The new federal recommendations from the ACIP serve as guidance, not mandates. This means that individual states will now face the critical decision of whether to adopt these changes or to maintain their existing vaccination policies. State laws are what ultimately determine which vaccines are required for school and daycare entry. As a result, the United States could soon see the emergence of a complex patchwork of vaccine requirements, with rules differing significantly from one state to another. This could create considerable confusion for families, especially those who move across state lines. Some states may choose to align with the new federal guidance as reported by NPR, a coalition of 4 Western states. California, Oregon, Washington, Hawaii is forming a collaborative aimed at preserving existing vaccine access and schedules, signaling a clear divergence from the new federal direction. For families, this potential fragmentation means that the vaccine schedule for their child could depend on their zip code. Parents will need to pay close attention to the specific requirements set by their state and local school districts. In this period of uncertainty, the most important action for parents is to maintain open and ongoing communication with a trusted healthcare professional. Your child's pediatrician. Your child's family doctor knows your child's specific health history and is the best resource for interpreting these new recommendations. Schedule a conversation to discuss how these changes might affect your child's immunization plan. Be wary of opinions and anecdotes on social media. Turn to official public health websites for factual information. Centers for Disease Control and Prevention, CDC website. Major medical organizations like the American Academy of Pediatrics provide evidence-based resources. Third, be proactive and organized. Keep a detailed, up-to-date record of your child's immunizations. Ask clear questions during your doctor visit. Finally, public health guidance can evolve. Stay informed and focus on protecting your child from serious diseases. Your doctor is your most important partner. Consult with them to make the best decision for your family.